My name is Sujievvan Chandran and I am the Endoscopy Fellow at the Austin Health in Victoria, Australia. I am proud to present our trial entitled Risk Stratification of Upper GI Bleeding with an Esophageal Capsule. We performed a diagnostic, non-randomized, single-blind study across 3 tertiary centres in Victoria, which included the Austin Health, Alfred Health and the Northern Hospital. This study came about after reviewing our unit's experience with upper GI bleeding management, which revealed a substantial proportion of our patients did not proceed to gastroscopy within 24 hours of presentation, as per the current guidelines. A review performed across the United Kingdom supported our findings locally, as they indicated that only 50% of their patient cohort had a gastroscopy within this time frame. Those patients in our cohort who did not proceed to gastroscopy at an appropriate time frame were predominantly low to medium risk. At present, the triage systems that we have are the Blatchford and Rockwell scoring systems. Current literature suggests that there's been a shift in patients presenting with non-varicose upper GI bleeding in Australia and overseas, as they are increasingly elderly with significant comorbidities. This shift negatively impacts the utility of these scoring systems to identify patients who would be safe for outpatient gastroscopy, often purely on the basis of their age and comorbid illnesses. The only studies assessing the utility of the PillCam-ESO in triaging patients with upper GI bleeding looked at whether it could identify a high-risk cohort of patients who may require rapid endoscopy. We felt that the technology may be better suited to identifying a low-risk group of patients who would be suitable for outpatient endoscopy. By identifying a large proportion of our cohort who could safely wait for elective endoscopy over and above the traditional scoring systems, it may result in a reduced hospital length of stay, after hours callback, and therefore reduce the financial burden on our health system. The first generation PillCam-ESO is seen here on the right, in comparison to the traditional small bowel capsule seen here on the left. The PillCam-ESO is an 11 by 26 mm video capsule endoscope, which is equivalent in size to the small bowel capsule. The specifications of the ESO capsule are that it has a light source at both ends. It has a 140-degree viewing angle. It captures images at 14 frames per second and has a total battery life of approximately 20 minutes. The current literature evaluating capsule endoscopy in upper GI bleeding is limited to 2 studies, as I've discussed earlier, whose primary aim was to assess the ability of capsule endoscopy to triage high-risk patients to rapid endoscopy. Our study, on the other hand, focused on whether we could identify a large proportion of our cohort who could safely wait for elective endoscopy. Whilst capsule endoscopy is not yet ready for prime time as a triage tool, when duodenal visualization is achieved, the capsule correlated well with gastroscopy findings and identified 92% of patients who may have been managed as outpatients. The associated financial impact of this would have been substantial if the capsule-based triaging system were utilised across our health system. Future studies are, however, required, as duodenal visualization rates are expected to improve with the next generation of capsule endoscopes. Thank you again to GIE for the opportunity to present our study.